Well, good evening, everybody, and welcome to this EFP webinar, the latest one in the series that's been going on since we've had all our global changes, and we have an excellent topic and an excellent speaker lined up for you this evening. My name is Mark Ide. I am the moderator for this evening, and I am the immediate past president of the British Society of Periodontology, so I'm speaking to you from sunny London. It was rainy London earlier, but now it's absolutely glorious sunshine here. I hope you're all ready and lined up for our session this evening. As I say, we have an excellent Andy Temmerman from Leuven in Belgium. He obtained his PhD in May 2017, and a year later was appointed professor in periodontology and oral microbiology at Leuven. He teaches head and neck anatomy and also teaches postgraduate periodontology students. And he has a range of research activities, including GBR procedures and sinus augmentation procedures and how these can be enhanced and developed. In addition to this, he's interested in the use of CAD/CAM, and particularly the topic for this evening, which is the use of L-PRF, which obviously stands for leukocyte and platelet-rich fibrin factors in periodontology and implant dentistry. Andy's been a co-author in over 25 papers in peer-reviewed journals, and he also works in a private practice, a prestigious private practice with his colleagues Stefan Matthijs and Martin Gliebert in Belgium. So he has a broad range of clinical, academic, and scientific experience. I'm really looking forward to this because obviously this is a topic which has been sort of on the sidelines to a degree, but slowly increasing in popularity and interest within the profession. And certainly we would all benefit from some up-to-date information and some real detail on what we can and can't do with these sorts of technologies. So if we move on, obviously this evening's talk is related to part of our overall EFP vision, and science and research relates to this. Education training is obviously a core part of this, training all members of the dental team. And on top of that, we are interested in our core vision, of course, which would be the health and well-being of our patients. And that's extending obviously now beyond the mouth into the broader systemic aspects of patient health as well. Obviously, these materials are the intellectual property of the speakers and the EFP, and we know and respect that you would understand that they're not to be modified, reproduced, or otherwise used without prior consent of the speaker or the EFP. So we know that wound healing is an important topic in dentistry and other medical fields, and people have tried for a very long time to try to find ways to accelerate healing. Platelet concentrates and similar materials have been used for quite some time, or explored for some time in sports medicine and orthopedics, and there are some data to support the use of these things. Now, the first generation of platelet concentrates, described as platelet-rich plasma products, were very expensive, and they came with complex preparation protocols. And there are now a second generation of these products developed in a slightly different way, which may have partly overcome some of these problems and made them more useful for day-to-day clinical practice. So this evening, we're hoping to focus on L-PRF as a surgical additive, its preparation protocol and usefulness in various procedures is going to be discussed and presented. And we're going to do this in light of current scientific evidence. In addition to this, we hope to also discuss potential shortcomings and, of course, explain what this potential technology can do, but also what it may not be able to do. So I hope that sets the scene. Really now, I just have to say over to you, Andy, and thank you very much for being prepared to do this evening.
So thank you, Mark, for this kind introduction, and also thanks to the EFP for giving us the opportunity to present just a little of our knowledge on the use of L-PRF, and for organizing these webinars in quite uncertain times. And a good evening dear colleagues, probably from all over the world, to listen to this short webinar. So, well, leukocyte and platelet-rich fibrin. Well, it has been quite some ride with this product over the years. It was firstly introduced at our department in Leuven, I think already 8 to 9 years ago. And since then, many things have happened. Well, the use of PRF spread all over the field of periodontology and implant dentistry and oral surgery, but there were also many believers, but also non-believers. But let's go back to 2014, and this is when I just gave my first lecture on PRF, and at that time we didn't do a lot of research on it in Leuven as we just starting to use it. So I went to see on PubMed what was in literature. And when I put platelet-rich fibrin as a mesh term in PubMed in 2014, I got around 909 hits. And I went to do the same thing in 2016. And there I could find 1,128 hits already. Now, during the quarantine, I also had, of course, the opportunity to update presentations and so on and so on. So I did the same thing in March 2020 when I was at home. And then you could see there was an increase from 1,128 articles going to 2,015 articles. And just to give you an idea what is happening in just from March till May 13th, you can see that there was already an increase of 15 papers. And I did the same thing just today, just to see what happens from May 13th to June 18th, and you could see that there was an increase of 31 papers. Just to give you an idea on how big the scientific interest in leukocyte and platelet-rich fibrin really is at the moment. Now, at the introduction of platelet-rich fibrin at our department, we were actually bombarded with these kind of pictures of very large and non-healing wounds. And as we all know, healing is a dynamic process that is consisting out of 4 continuously overlapping and precisely programmed phases. And the events of each phase must happen in a precise and regulated manner. And any interruption, aberrancies, or prolongation in the process can lead to a delayed wound healing, or eventually a non-healing chronic wound, such as chronic pressure ulcers or diabetic wounds. Now, with only the use of L-PRF in this chronic pressure ulcer that has been there for 22 years, Professor Pinto was able to close these wounds in approximately 14 days just by the use of L-PRF. Now, there are 2 possibilities now. Is this real, or is this, let's say, I could say, is this not real? So did we have the opportunity to get the same results when it comes to wound healing as Professor Pinto did with this case? And I'm just going to show you how we were able to replicate. So, well, at the time PRF was introduced in Leuven, Dr. Yannick Spy, who is a maxillofacial surgeon at our university, also started to use PRF on skull cancers, for example. And here you can see just one of the patients that he operated on, and where only PRF was used to cover the excision, and you can see the healing after 1.5 months and after 1 year. And now, of course, he is getting also referrals for very large non-healing wounds, and what you can see here on the screen is just one of them. And also myself, I did some patients together with the Department of Dermatology. So yes, we were able to replicate these results when it comes to wound healing properties of L-PRF. And in this 2018 paper that was published in Platelets with help of our department, here you can see a couple of patients that were treated with vascular leg ulcers on the left, smaller than 10 square centimeters or bigger than 20 square centimeters on the right. And you can see that just by putting L-PRF week after week, even very large non-healing wounds, we were able to diminish the surface immediately after 3 to 4 to 5 weeks. And even for diabetic foot ulcers, in this study, Professor Pinto was able to do this. And just recently, a couple of weeks ago, before the COVID-19 crisis started, we had a congress in Leuven where a lot of medical doctors from all disciplines gathered to gain insight in how PRF can be of utmost importance when it comes to enhance the wound healing characteristics. So it was very nice to see for myself and for Professor Grenell also that also outside of dentistry, this product now is getting its attention it deserves when it comes to its wound healing capabilities. Already around for some time, and the first generation, like Mark already told, of platelet concentrate, the so-called PRP-like products, were firstly described in the 1980s. And the big drawback of PRP-like products were that they were very difficult and expensive to prepare, and they needed to add calcium chloride or bovine thrombin, which was very difficult in day-to-day use and in day-to-day practice. Furthermore, there was a variety of preparation protocols, making the available literature very difficult to interpret. And this is something that we have to be aware of now when we are talking about the second generation platelet concentrate, or PRF. Now, at the department, we are using the original protocol as that has been described by Joseph Shukroon and David Tuhan Ehrenfest. So we take 9 milliliter tubes and we fill it with venous blood, and this is immediately centrifugated to obtain a blood clot that is containing the majority of leukocytes and platelets without the inclusion of the red blood cells fraction. At 2700 RPM for 12 minutes and with 408 G. And this force is of utmost importance and should be checked depending on the centrifuge which you are using, and we will come back to this in just a moment. Now, the time between the venipunction and the centrifugation is of utmost importance, as can be seen on this picture. So this is the work from Dr. Ana Castro, and she did this work for her PhD thesis. And as you can see, when we are able to put the tube into the centrifuge in less than 1 minute from the venipunction, we will end up with a very nice PRF membrane. When we wait longer, the size and indisputable the biological activity of the product decreases. And even if you see we wait for 7, 10 to 15 minutes, we were not able to create a membrane whatsoever. So we have seen that the time between the venipunction and putting the tubes into the centrifuge can lead to immense differences between the end products. And the same is true for different types of machines, as we have to be aware of the fact that even a centrifugation at the same resolutions per minute will exert different centrifugal forces if the centrifuge rotors have different radius sizes, bucket types, or bucket sizes. So depending on the time of spinning, the speeds, the g-force, the rotor diameters, the angulations, and the vibrations, we will end up with different end products. And higher g-forces, unfortunately, will have several negative effects with significant impact on the outcome of the product. That means a higher g-force will push more cells to the bottom of the tube, and as such will reduce the cellular content of the clot. And at higher g-force, the PRF clot becomes poorer in platelets and in leukocytes, and as such will release less growth factors. And also at higher g-forces, the radial vibrations will exponentially increase, which will have a negative impact on the clot formation, but also on its dimensional fibrin network. Now, if you want to know more on this behalf, I would suggest that you will read these two publications, which you can see on the screen, that will go into more detail. Now, when you have done your preparation protocol exactly perfectly right, you will end up with this end product. You can see on top the acellular plasma, in the middle the PRF fibrin clot, and in the bottom you can see the red blood cells fraction. Now, all you need now is a compression kit, tweezers, and a periosteal elevator or a spatula. So the clot is taken with tweezers on top of the clot and it's pulled out of the tube. And then the periosteal elevator or the spatula is used to scrape off the red blood cells, which are quite firmly attached to the fibrin clot. And I say scraping and not cutting. Yeah, so don't use scissors to do that. Just scrape off the red blood cells parts, as cutting will lead to the fact that you will cut off the most biologically active part. And normally, if you are a little bit trained in this, you can catch up the red blood cell fraction into the tube. And the same is done with the rest of the clots. And as you can see, if you have done the preparation protocol correct, you will end up with clots that are very equally in size and in color. And then by just using compression and let gravity do its work, you will end up to the membranes, again, quite equal in size for all the membranes. Now, when it comes to the methodology, there are quite some differences between the first generation plated concentrate, so the so-called PR3-like products, and the second generation, the PRF products. And as you can see here in this graph, you can see that PRF, there is no need for anticoagulants, no need for calcium chloride. You don't need to go to a second tube. There is no expensive laboratory supplies. There is no incubation, there is no biochemical handling, which was the case for PRP-like products, and even partially for PRGF-like products, which was also first generation plated concentrate introduced by Amituwa in the end of the 1990s. And when it comes to the properties and the handling of it, there is a very big difference. Whereas PRP or PRGF, by definition, are plasma-like products and therefore fluid-like, they don't have the same easiness in handling as a fibrin material. Now, indeed, PRF can be used as a membrane. It is suturable. We even have made sutures from it just as a proof of principle. You can cut them in various shapes. It's 100% autogenous. It's quite inexpensive to prepare. There are cytokines that are trapped into the fibrin. It's slowly polymerization, and it contains, of course, the leukocytes. And of course, there is a difference when it comes to the protein release and the biological activity between the first and the second generation. Whereas the first generation was able to release transforming growth factor and platelet-derived growth factor for approximately 20 minutes, PRF is able to release transforming growth factor, PDGF, VEGF, IGF for approximately 7 days, which has been shown also by my colleague, Dr. Ana Castro, in recent studies. So over time, PRF has been used in various types of treatments, from alveolar ridge preservation to sinus augmentation procedures to bone regeneration, soft tissue surgery, even peri-implantitis treatment and medication-related osteonecrosis of the jaws. And now we don't have the time to go over them all, so I've just chosen a couple of topics which we will briefly discuss. And we will talk about the use of L-PRF in alveolar ridge preservation, in sinus floor elevation procedures, and in the soft tissue augmentation peri-implant. Let's start with alveolar ridge preservation. Now we know that from a background point of view that the alveolar ridge preservation is a very interesting thing, and there are a lot of scientific investigations that are coming down to the question, what really happens when a tooth gets extracted? What happens biologically, aesthetically, volumetrically? And there was a peak already in the 1960s, and a second peak, scientific peak, came end of the 1990s, where a lot of scientific investigations were done, definitely in the group of Gothenburg, where they systematically explored the extraction sockets. And in this systematic review by Tan and co-workers, he could include 20 randomized controlled trials on this subject, just on what happens with the dimensional changes after tooth extraction. 20 randomized controlled trials just to show how much effort was taken to understand extraction sockets. Now, in this systematic review, from a horizontal point of view, more than 50% of the alveolar ridge width was lost 6 months after extraction, and from a vertical point of view, it was 11 to 22%. And of course, this is due to the fact that only single tooth extractions were included in this systematic review. So definitely it's the attachment of the neighboring teeth that are very important. And when we are performing multiple extractions, this issue becomes even more and more complicated. And there are, of course, influencing factors, traumatic extractions, raising a flap, smoking, etc. Now, when it comes to the methods that have looked into possible options to at least partially overcome the problem of rich resorption, the so-called filler materials, I frequently refer to this study that was published by Ronnie Jung in 2013, and he compared unassisted socket healing with beta TCP and DBBM with a collagen matrix or a soft tissue punch graft. And here you can see some Conium CT images after extractions and after 4 months of healing. And then, of course, he performed some very interesting measurements on that. And he had very good results with the DBBM and a soft tissue graft on top. And he was able to reduce the crestal width reduction approximately to 15 to 20%. So these alveolar ridge preservation techniques, do they really work? Yes, they work, but they are not perfect. And in this technique, a free gingival graft is taken from the masticatory at the palate and is sutured nicely over the extraction socket. And why would this be beneficial? Well, of course, you will achieve healing by primary intention. And well, if 6 to 8 weeks, you will re-enter, you will have the best tissue quality. But nevertheless, inside the socket, there is a xenograft material. And now, how long do we wait before placing the implants? And what will we find underneath of the soft tissues after 3 to 4 months? Furthermore, it's quite expensive for our patients. And now, of course, when we have materials such as L-PRF membranes, wouldn't that be beneficial to place these materials into the extraction socket? And what would happen then? Well, the first case on this technique that I could find actually was where the use of PRF was described after extraction is this study you can see on the screen, and this was also done before implant placement. But of course, this is just a case report, and this does not give us the evidence that we really need. So it wasn't until 2013 with the study by Hauser and co-workers and 2015 with the study at our department that we were getting the first results on how PRF could be beneficial when it comes to alveolar ridge preservation procedures. Now, I will go over this video once more to describe the technique in detail. So, of course, we will go for an extraction as atraumatically as possible. We will clean the socket and remove the sulcular epithelium, and then some sort of pouch is created buccally and palatally. And then we start plugging the membranes, and this can be hard because the material itself is quite slippery. So it takes the time to do, so you have to take your time to do this very properly. And at least 3 membranes should be used as a plug into the socket, and on top 2 layers of membranes will be slipped into the pouch. And then a fixation suture will be used. The entry point of the needle is next to the alveolus. Yeah, various type of techniques can be used. In this video, you can see a cross horizontal mattress suture. It can be a modified horizontal mattress suture. This is at your discretion or what you really like. You see, there is no attempt to close the socket. It's just the suture is only there to support the material into the socket itself. Now, this is the study we performed at the department in Leuven. So we included 22 patients in a split mouth design. So they were scheduled for bilateral extraction of similar teeth. And one side was left for a spontaneous unassisted healing, and the contralateral test site was filled with L-PRF according to the technique I just described. Conium CTs were taken immediately after extraction and after 4 months of healing to perform some radiological measurements, and we also performed some clinical measurements. And here you just can see a couple of patients of the test sites and the control site respectively, and you can appreciate the difference between the test and the control sites. So you can see definitely at the test site, also in this case, there is a much better healing than at the control site. Another case here with the loss of the vestibular bone plate, you can see that there is a nice regeneration at the L-PRF test site and not as good a healing on the control site. Now, measurements were done according to the method that was described by Ronnie Jung in 2013, the aforementioned study. And the horizontal width was measured at 3 levels, meaning 1 millimeter below the crest, 3 millimeter, and 5 millimeter below the crest. Also, the vertical height changes were measured buccally and lingually. And these are the numbers, but to make it a little bit more easy for you, I put them into a graph. And here you can see the horizontal width measurements at -1, -3, and -5 level for the control group. So you can see that the control group was actually losing 52% of the original ridge width after 4 months. And this, what in the L-PRF group, this was approximately 23%. Now, what I done now is I just try to compare both studies, because in the Ronnie Jung study, there were a couple of measurements were done, and we did the same measurements in our study. Of course, comparing studies is not really the thing that we should do, but just to give you an idea on what the PRF results really are. So in gray, you can see here the horizontal width reduction for my test group, so for my control group, so the unassisted socket healing. And in red, you can see the L-PRF group. And now in yellow, you can see the ridge reduction when Ronnie Jung did an unassisted socket healing. So he lost approximately 47%, which is a little bit less than we achieved in Leuven. And then when he performed a DBBM with a soft tissue punch on top, he was able to reduce the alveolar ridge width reduction to approximately 18 to 19%. So is L-PRF as good as the DBBM plus the collagen plus the soft tissue punch? No, but it's quite coming next to it. So it's quite in the same area. What we also did in this study, we looked at the pain sensation for the patient. So we asked to the patient on which side there was more or less pain, and they have to score it on a visual analog scale. And now you can see here in this graph, so for the control group, so the unassisted socket healing, the worst pain, and for the L-PRF side, the average amount of pain unassisted, and the average amount of pain for the L-PRF side, and the weakest amount of pain for the unassisted socket healing and for the L-PRF. And this was statistically significant difference for the worst amount of pain and for the average amount of pain going from day 1 to day 4. So there is also definitely some reaction for when PRF is used into an extraction socket when it comes to the pain sensation for the patients. Now take a jump 4 years, and now we have a look at a very recent study by Canellas, just recently published. And what did he do? He did the same thing as we do, but this is a parallel study, randomized controlled clinical trial with no non-molar extractions in 48 patients. So the control site was the unassisted socket healing. The test was the PRF. He did some measurements on cone beam CT, but he also did histomorphometric evaluation. And here are the values that he was able to obtain. And now we're just going to put our values in our study of our department underneath them. And now you can see the differences. So the results that Canellas had in 2020 were very, very similar to the ones we were able to obtain in 2016. So it seems to be reproducible. Now, when we look at the histomorphometrical analysis, they looked at the new bone formation. In red, you can see the L-PRF test group, and in gray, the control group. And they saw that from new bone formation, the L-PRF was statistically significant, different from the unassisted socket healing. When it came to the new bone formation, also this was statistically significant. The immature bone, there was no statistically significant difference, and the fibrous tissue was statistically significant difference when it comes to the PRF and to the test group. Now, you can see that since then, a lot of systematic reviews have also been published on this behalf. And we don't have the time to go over them all, but I would just want to show you a couple of them. So this is the one by Ana Castro, published at our department in 2017. And she could conclude that most studies confirmed that L-PRF decreased the healing time as well as reduced the resorption of the buccal plate after extraction. In this systematic review by Strauss and co-workers from the EAO consensus meeting, he could conclude that based on the studies with rather limited statistical power, the present reviews suggest that PRF might reduce alveolar with resorption. And the most recent one is the one by Lee in the IJOMI. It could say that there were small sample sizes with short follow-up times, and that there was an inconsistency when it comes to preparation protocols, and we have talked about this already. I just throw in one case. So this is a case by Dr. Simone Cortellini, where we extracted the tooth and placed PRF into the socket according to the protocol we have described in the video. This was pre and this was post. You can see the fixation suture. This is the healing after just 1 week, and you can see the nice healing which you can expect from this material. And this is the healing after 3 months. And here he was able, just by using a pilot guide in order to have the correct three-dimensional position of the implant, he was able to place the implant without any form of augmentation procedure. This is the implant osteotomy. You can see that here is an implant placed. It's a little bit sped up, of course. We don't place the implant that fast normally, but it's just according to the movie. And then you can see that this was the healing before surgery. This is with the roll flap technique and the healing abutment in place. This is at impression taking before extraction with the healing abutment. And this is now with the temporary crown on top of it. And this is the radiograph, as you can see. So now we switch over to sinus floor elevation procedures. Now, the first thing that we can discuss is whether PRF can be used as an antrum filling material. And in this systematic review, they looked into the morphometric results of different grafting materials. Now, various combinations are tested and used, but there was not really a clear gold standard. Even combining autogenous bone with other xenografts brings no significant advantages when it comes to new bone formation, which is rejecting the hypothesis that autogenous bone might have a role in favoring new bone formation when it's adding in sinus augmentation procedures. Now, the first paper that addressed the use of PRF during sinus floor elevation procedures is this one by Shukroon in 2016. And in this study, histological evaluations were performed on the effect of PRF on bone allograft maturation. And they could see that the histological maturation of the test group being PRF together with an allograft at 4 months was identical at the one of the control group of the allograft alone at 8 months. And although this was not a randomized controlled trial, it was hypothesized that by adding pro-angiogenic growth factors into the maxillary sinus, where the blood flow is of course reduced, bone cell migration from the maxillary sinus walls could be increased and thereby speeding up the ability for osteoblasts to form new bone. And more recently, the use of PRF as a sole grafting material using both lateral and transcrestal approaches has been published. And for this purpose, it's an absolute prerequisite that implants are placed simultaneously, as they can act as a space-creating device to provide space for bone to grow into. And we all know, of course, that there are studies that even have done the same thing without any form of graft material whatsoever. Now, we just look at a recent study from our department by Dr. Molemans and co-workers, and he looked at patients that had sinus floor elevation procedures, lateral ones and transcrestal ones, with just PRF as a sole grafting material. And in all patients, he was able to get an increase of the amount of bone. And you can see on the right-hand side the residual bone that was there at the time of surgery and the changes that he was able to obtain in the different groups. And just some examples you can see here. So this is, of course, a lateral sinus floor on top, and you can see the follow-up during the months and years, and you can appreciate the nice sinus augmentation volume that he was able to achieve. Now, the addition of PRF to biomaterials is of course more common, but several authors now have shown that PRF alone is also possible to result and is resulting in various amounts of vertical bone gain. So we now have to understand that these studies are merely focusing on radiographic bone gain, and due to the lack of controls, of course, these results should be interpreted with care. Now, on the other hand, the group of Professor Thor in Uppsala in Sweden have already multiple publications with long-term follow-up of my maxillary sinus floor elevations and simultaneous implant placement with no grafting material at all. It has been shown that approximately 20%, and in my hands even more, all sinus lifts report a membrane perforation. A recent systematic review concluded that the use of piezosurgery, for example, could significantly decrease the incidence of these kind of ruptures in the Schneiderian membrane. Now, there are various ways of handling these type of complications depending on the size of the suture. Very good surgeons, for example, can suture it. I've tried it multiple times, but the only thing that I ended up with when I tried to suture the Schneiderian membrane is that I just enlarged my rupture. So I stopped doing this. A possible alternative would be to use L-PRF membranes, and definitely when you have a small rupture, this is the ideal material to do this. It's a very sticky material, and it adheres quite easily to the rupture itself. Of course, when the rupture is bigger, you are a little bit confronted with the size of the PRF membrane. So if this rupture is going really big, then sometimes you are in need of a collagen membrane, which is, of course, is a little bit bigger when it comes to the size. And these kind of things, they really work. And do they really need scientific evidence for this? I don't think so. I think we can be clearly be clear that PRF membranes definitely are usable to fix or to repair a rupture in the Schneiderian membrane during sinus elevation procedures, and there are a couple of studies to support this. Now, when it comes to the lateral window, now this not seems to be a prerequisite to do this, but we can talk about the cost effectiveness for the patients, the coverage of the lateral window with PRF membranes. Would that be really an option? And there is only one study that has compared the use of collagen membranes with PRF membranes when it comes to the coverage of the lateral window. And this is the study by Gasling. He included 6 patients with a split mouth design, and they were receiving bilateral sinus floor elevation procedures. And one side was randomly assigned to the resorbable membrane group to cover the lateral window, and one side to the PRF group, as you can see on these images. And he also performed histology on biopsies after 6 months, and here you can see a couple of examples, but just look at the results. And here you can see the percentage of vital bone between the collagen group in gray and the L-PRF group in red, and the remaining bone substitute. And there was actually not really a statistical significant difference. Please keep in mind that the y-axis, they're going from 17.5 to just 15%. So the differences between them are actually very small. Let's jump to the last section of this webinar, and these are the peri-implant soft tissues. Now, there are a lot of things that we can discuss when it comes to the peri-implant soft tissues. First of all, we can talk about the keratinization. And in science, this is, of course, measured as the width of the keratinized mucosa. We can talk about the thickness. Is it on top of having a keratinized mucosa? Is it also of importance to that mucosa is on top thick? And also, what about the attachment? Is it important that the peri-implant mucosa is also attached to maintain a healthy situation? Now, of course, what does this mean clinically? It is possible to achieve a keratinized tissue and increase tissue thickness. Yes, you can see in this very recent systematic review that it is possible to achieve this with the free gingival graft or connective tissue grafts, but also by using substitute materials like acellular dermal matrices or collagen matrices. They seem to work, but not as good as the autogenous neighbors. Now, well, if we start with the soft tissue management, I think we can all agree that this involves some extra surgeries, extra morbidity for the patient, but this does not always need to be. If you are, the goal should be that achieving peri-implant mucosa that is keratinized, thick, and on top of that attached should be included into regular implant therapy and should be discussed with the patient from beforehand. Now, of course, these things are we using. Here you can see a free gingival graft that is used as a strip. Here you can see connective tissue graft, and I would like to thank Professor Sarata Aslan for these very nice pictures. And here you can see a free gingival graft from a picture under the microscope. Now the question is, do these PRF membranes, are they able to replace all the autogenous materials that we have just seen? And this is, of course, would be of very big interest for our patients, not having to go under a second surgical site. Now we have done this. We have looked into this in this study. We have looked at L-PRF as a free gingival graft replacement, and this was just a proof of principle study. So we included 9 patients with a split mouth design. At the control site, we used a vestibuloplasty with a free gingival graft, and at the test site, we used a vestibuloplasty with PRF. And we performed Lugol staining measurements in order to see what we ended up with, and we also did the pain sensation for the patient. Now, in both groups, we were able to get an increase of the amount of keratinized tissues. In the L-PRF group, it was a little bit less than in the free gingival graft group, but both sides seem to work. But if we be very honest, the L-PRF group was a little bit less stable than the free gingival grafts. So my preference nowadays still goes to the free gingival graft. The PRF might be an alternative, definitely for a patient that is not willing for you to go to the palate, but be careful with this. The free gingival graft remains the gold standard when it comes to these kinds of procedures. Furthermore, the use of PRF during a vestibuloplasty as a replacement of a free gingival graft is technically much more difficult because PRF is very slippery. So it's very difficult to control. It's very difficult to suture. So be careful when you are using this material. But yes, we were able to enhance the keratinized tissues around implants. Now, when we looked at the pain sensation, and this is of course quite interesting, but also very normal. Of course, the patients that were in the L-PRF group, they had less pain than the free gingival graft group because there was no secondary surgical site, of course. And here you can see the differences. On top, you can see the worst pain in the control group and in the PRF group. This is in blue the control group, and this is the PRF group, and the least amount of pain in yellow for the control group and for the PRF group. So you can see this was statistically significant difference. And this is just an example. So this is a free gingival graft. Here you can see the free gingival graft taken from the palate. And this is what we end up with for our patients. Now, the question is, we started this presentation with the healing capacities of PRF itself. So now, if we would use PRF to cover the wound on the palate, would that be an advantage? Well, of course, that would be an advantage. Yeah. So do we do this? Yes, we do this on a regular basis. So here you can see a free gingival graft. We put PRF on top like this. It's just a normal suture, and this is the healing you end up with after just 2 to 3 days. And there is quite some evidence to support this. This is just one study. 24 patients were randomized, divided into 2 groups: the free gingival graft group and the free gingival graft group, where the donor sites were covered with L-PRF membranes. And there, of course, was a difference when it comes to the pain sensation, as you can see here in this graph. Of course, you have to put this into perspective. because we know from studies by Reno Burkhardt that it also make a difference how deep we go at the masticatory, at the palate. But definitely when it comes to a wound healing point of view, PRF has a quite good properties and is advised to use in these kind of circumstances. So as a couple of take-home messages, I would say that PRF is a 100% autogenous product, which might be used beneficially in various types of tissue regeneration therapies, and we have just seen a couple of them. The preparation protocol is fairly easy if you take certain measurements into account, quite inexpensive, and although the amount of literature is very considerable, we are still in need of very well conducted randomized controlled trials in the field of periodontology and implant dentistry. And therefore, I think we should not be a variety of preparation protocols at the moment. Why don't we stick to the original protocol so that everyone uses the same protocol, so that we are able to compare our results in studies, but also in the clinical field. And with this, I would like to thank my team in Leuven, the Perio team. You can see the names on the left-hand side, and some, if you want to see how we are doing at the department, you can follow us on different social media. So I think I can go over to the moderator, Professor Ide. Word is to you.
Okay. Hopefully you can hear me now.
Yes.
Fantastic, good. So thank you, that was a brilliant presentation, and we did have some questions that came through whilst you were there talking. Before we do that, I just want to remind you that we have another webinar coming up in a week or so, next Thursday, with Johan Volber, talking about the role of diet, which is another interesting and potentially contentious, or at least area which is prone to intense discussion at the moment. So that's something for next week. But let's just go back to this now. So a couple of questions that have arisen during this session. The first one was around, but there were two around basic principles. And the first one of those was, what do you think is the optimum time between collecting the sample and getting it to the centrifuge? Is there a minimum, maximum, optimum?
Yeah.
Like
can you still hear me?
Yep.
Yeah, okay. So there is that, like I've shown you in the picture by Dr. Ana Castro. So he has tried different times between the vena punction and putting the tubes into the centrifuge. Just keep in mind that when the time you are starting the vena punction, the tube should be into the centrifuge and also spinning, of course, in under than 1 minute. Then you will end up with the best product. If you, of course, most of the times you will use 6 to 8 tubes. And how do you do it then? Well, you take the first tube. If it's under 1 minute, for example, 30 seconds, you can also take the second tube, and then you put the 2 tubes under 1 minute into the centrifuge, and you let them spin already. On the meantime, the vena punction is still running. So when you have the next 2 tubes, you stop the centrifuge, you put in the 2 next tubes, and you start the centrifuge again. So this means that the first 2 tubes that will be inserted into the centrifuge, that they will be into the centrifuge for 1 to 2 minutes longer. But this is not a problem. It's more important that the tubes are into the centrifuge under 1 minute.
Okay, and obviously that means then you have to have a very organized team and process. Just out of interest, how long did it take before you had a system working within your practice and with your nurses and team to get that to be super slick?
Well, at the university, it went quite fast because we have a big team. We have 1 supervisor, we have a couple of postgrads, we have a nurse, and so on. But if you look into private practice, because this is, I think, for most of the colleagues, the most interesting part, I think they should be aware that this takes 2 to 3 hours to put this into practice. They have to make yourself as a test patient and let them do it. Yeah, and from that moment on, there is not really a problem anymore. So what most of the time what we are doing, or my nurse takes the blood, or I'm taking the blood, and there is an extra assistant that is putting the things into the centrifuge. Now they are trained to do this, so they know when to stop the centrifuge to put in the next one in. So actually now in our private practice, this is going without any problem. Yeah, so but it takes like 2 to 3 hours, just like a test. Do 2 or 3 test cases with yourself as a patient, and then normally this should be not really a problem.
Yeah, sure. That sounds very sensible. Just like organizing a new implant protocol or anything like that, basically.
Something like that, yes.
Okay. The next question, the other sort of basic technique question around that was, what is the ideal G-force? Because apparently some of the older papers are quoting around 400, but more recent papers have quoted around 700 G. Is there an issue or something that's changed there?
Yeah. Well, of course, like I said, depending on the centrifuge you are having, and depending on the rotor diameters, and the 2 papers I showed are going into detail on this. This is the original protocol has resolution, a centrifugal force of 408 Gs, and I think we should stick to this. I know there are protocols now that will have less and more G-force, but until we do have the real evidence that this really makes the difference, I think we should stick to the original protocol. My colleague Ana Castro has looked into this. She has performed a lot of in vitro experiments, doing cell count and so on and so between different preparation protocols, and actually the difference that she could find are very minimal for the moment. So we are sticking to the original protocol, being the L-PRF protocol as described by Shukroon and David de Juan Ehrenfest, with the 408 Gs, 12 minutes at 2,700 RPM in this originally designed centrifuge.
Okay, fantastic. So going on, there were no particular questions about the antral part of the talk, but there were some questions around socket preservation. Do you think there are particular criteria then when you should be carrying this procedure out for socket preservation? I mean, obviously, as you pointed out, we don't want there to be any major issues, but are there any other particular physical or anatomical things that one needs to bear in mind? And on top of that, do you think the presence or absence of the buccal plate, or how much buccal bone you have, is something to be considered?
Yes, of course. I think the presence or absence of the buccal plate is, of course, an immensely important factor. The difficulty is that in most of the papers that are now published, except for mine and another one by, I cannot recall the name anymore, but the paper we have discussed in detail, we have actually included also patients where there was a loss of the buccal bone plate. And I think it's definitely in these situations that we want the material to work. Because if there is a thick buccal bone plate, we know from studies, if there is a 1 millimeter buccal bone plate, that the ridge resorption will be minimal. So we want this material to work when there is not a buccal bone plate. So what do you take in mind when you are performing the alveolar ridge preservation? Well, a big mistake that has been made in a couple of studies is that they are just putting one membrane inside. So they extract the tooth and then they drop one membrane, and then they think that magically this will become bone. Well, this is not the case, of course. This is to perform an alveolar ridge preservation technique for a single incisor or for a central incisor. This takes time. You have to insert 3 to 4 clots. The material itself is quite slippery, so it takes time to do this properly. Then you have to create a little pouch. You have to slip in the membranes, and then you have to take in consideration that also the suturing is of importance. So there are a couple of things that you really need. For example, if you extract a central incisor, you need 6 tubes, six PRF clots to do this in a proper way. And that is one of the biggest mistakes. Even if you have a buccal bone plate, maybe you should make your pouch a little bit bigger so that you can slip in the membrane a little bit more, overbuild a little bit, not trying to close it. So definitely, this is it's from a surgical point of view definitely a little bit more. For myself, I think it's a little bit more difficult than doing this with a biomaterial. Yeah, because of the properties of the PRF itself. But nevertheless, when it works, you will end up with bone and not with a xenograft inside of the socket.
So when you're doing that, and you talk about creating the pouch, do you mean a periosteal pouch over the little piece of sort of the most coronal part of the labial plate, as it were?
Yeah. If there is no loss of the buccal bone plate, then it's just like 1 to 2 millimeters that you are able to just go a little bit underneath so that the membranes are a little bit fixated. It's not the idea to raise a flap, of course. We know that this is not the point. We don't have to do this. Yeah. But of course, if you have to go a little bit deeper, then sometimes you have to perform some sort of, maybe it's not a correct term, but some sort of tunneling so that you can go a little bit underneath so that you can put the membrane in a nice position.
A sort of a sharp dissection, basically.
Yeah, something like that. Yeah.
And okay, and then when that is seated back, obviously you want to have tension-free closure, which may mean that you don't have too much. You're not going to get primary closure anyway. Are there issues there about how wide you're prepared to let a socket be, as it were, in terms of what you think can be achieved by healing, or does that not matter?
No, the nicest results we've got when it comes to alveolar ridge preservation is the ones that are lost a little bit of the buccal bone plate, and we managed to over contour and then just leave the material with no intention to try to close it. That is a mistake. Yeah, you just have to leave it open. You will also see that if you do this and you see the patient after 1 to 2 days, you cannot take the membranes out anymore because they are glued, like I showed you the pictures of the wounds of my wife. After 1 day, you could not see the difference between the membranes anymore. So they were all glued together and fixed to the wound itself. And the same happens in a socket. You cannot pull it out anymore. So so the suturing is just there to fixate the material during the first hours, so that the patient is not able to, let us say, suck it out.
Yeah, sure. Okay. How long would you leave it when you reviewed the case before you considered doing a further intervention, as it were? How long do you think it needs? Just the normal amount of time, say 2 to 3 months, or less, or more, or?
We normally wait 3 months, 3 to 4 months. Of course, there are cases where you know that you are going to need an augmentation procedure. Those cases are, of course, still there. Sometimes you can have a miraculous healing, but there are still a lot of cases where you're going to do a bone augmentation procedure. Nevertheless, then the PRF is there to give you the best soft tissue quality, which you will need for your augmentation procedure. So, and what you have gained with just doing the PRF alveolar ridge preservation is just an extra you gain before you do the bone augmentation procedure. Yeah, that's the idea. So if we know that there will be an augmentation procedure necessary, we go in at 6 to 8 weeks.
Sure. Okay. Those aren't just about all the questions that came through. There was one other thing I was interested in terms of the stability of the outcome. Obviously, one of the sort of semi-benefits of using some of the bovine products might be that they just don't resorb. They just sit there in perpetuity. What do you think would happen with the alveolar ridge with these materials? Do we have any data on that at all?
Well, of course, if you put PRF, there is no biomaterial into the socket, so you can think about the fact that this will become bone because it's just an optimized blood clots whatsoever. So of course, we have published some studies on that. Professor Joe Merrick had looked into this. What happens with the buccal plate over time? if you place an implant without any augmentation procedure, what happens with the buccal plate? Does it stay there? And he looked into this, and it's a very nice study. It's called The Fate of the Buccal Bone. And he saw that over time, there is a change when it comes to the amount of bone. But do we really need that? That is still the question in implantology nowadays, I think. We still do not really need how much bone we really need. So it's a difficult, it's maybe a little bit of philosophical answer for the moment.
Okay, that's fine. Right, I think that just about wraps it up to our last question, really. So
Yeah.
I need to say thank you for that. That was a fantastic session. So I just need to do one other thing now, hopefully, and we can move on. There we are. So as I mentioned earlier on, we have our next speaker in about a week's time, and on top of that, if I can get this to work, there we are. I need to remind you that the EFP has made available safety protocols and recommendations that were developed, hopefully, to help you manage as practitioners in dealing with patients in the current situation. We obviously, these are superseded by any local and national guidance that you may have, and on your country there may be different levels of guidance and different levels of recommendations, but certainly we hope that these are some kind of useful aid in establishing what can and cannot be achieved and how to do it. And finally, we do need to remind you, of course, that despite everything, we are still carrying on with planning for EuroPerio 10, which we're looking forward to next year. And you'll be regularly informed about this through the website, through mailings, and on social media. So I think that's all my slides and our presentation finished. I hope you've enjoyed it this evening. I think we've had a fantastic presentation, really good today. Answered lots of questions. Thank you for listening and have a good evening.